Extract 1. Questions 1 to 12. You hear a doctor talking to a patient called Eugeniusz. For questions 1 to 12, complete the following notes with a word or short pause. You now have 30 seconds to look at the notes.
Hello, Doctor. Good morning.
Good morning. What's your problem?
Doctor, he is my son, Eugeniusz. A few hours ago, he fell off his bicycle. He was not wearing a helmet. He went unconscious for a few seconds. He complains of neck pain now.
Does he have any other illness?
No, Doctor.
Okay, what's his age?
12 years, Doctor.
Any previous injuries?
Very minor injuries, Doctor.
Was he taking any medicines?
No, Doctor.
Does he smoke or drink?
No, Doctor.
Can you tell me more about family history of illness?
Absolutely no illness in our family, Doctor.
Any weight loss or gain recently?
No, Doctor.
Well, his physical examination shows his blood pressure 150/75, pulse rate 80, respirations 18, temperature 37.4, saturation 97% on room air. He is moderately obese. His neck is symmetric, the trachea is in the midline, and there are no masses. No crepitus is palpated. The thyroid is palpable, not enlarged, smooth, moves with swallowing, and has no palpable masses. Normal respiratory effort. There is no intercostal retraction or action by the accessory muscles. Normal breath sounds bilaterally with no rhonchi, wheezing, or rubs. The point of maximal impulse is palpable at the 5 ICS in the MCL. No thrills on palpitation. S1 and S2 are easily audible. No audible S3, S4, murmur, click, or rub. Abdominal aorta is not palpable. No audible abdominal brutes. Femoral pulses are 3+ bilaterally without audible brutes. Extremities show no edema or varicosities. Gastrointestinal investigation shows no palpable tenderness or masses. Liver and spleen are percussed, but not palpable under the costal margins. No evidence for umbilical or groin hernia. No lymphatic nodes over 3 mm in the neck, axilla, or groins. Musculoskeletal test shows normal gait and station, symmetric muscle strength and normal tone without signs of atrophy or abnormal movements. There is a hematoma in the forehead and one in the occipital scalp, and there are abrasions in the upper extremities and abrasions on the knees. No induration or subcutaneous nodules to palpitation. I have reviewed his chest X-ray and it is normal, right hand X-ray, which is normal, and an MRI of the head, which is also normal. He has concussion, facial abrasion, scalp laceration, and knee abrasions. Admit him today and his health condition will be monitored by our team. We have observation team working 24 hours.
Extract 2. Questions 13 to 24. You hear a doctor talking to a patient called Daniel Anderson. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi, it's Daniel, isn't it?
Yes, Daniel Anderson, that's right. Hi, Dr. Hampton.
I haven't seen you for quite a while. What brings you in today?
Yeah, I probably should have come in before now.
Okay, well, that's fine. So how can I help?
Well, basically, over the last couple of weeks, I play football on Sundays, and a bit more than a couple of weeks ago, I was getting a bit more tired than I used to be. Like, I'd get out of breath in the game, I'd get puffed out. But more recently, it's been little things like walking up and down the stairs and stuff like that. That's got me a bit tired as well. So I was just wondering what's wrong with me, really?
Okay. When did you first start feeling poorly? Can you remember?
That's the thing. I had a cold, you see. Well, I thought it was a cold. I had a sore throat, and I was quite under the weather for that, but I've never really recovered since then.
And how long ago was that?
That'd be about a couple of months ago now.
Couple of months. Did we see you with that?
Well, so I made an appointment on the phone, but I didn't come in the end.
No, I didn't see you on the computer. So you just basically managed that yourself and,
Yeah, I thought it was getting better, but it's never really... I suppose that's never really gone away entirely. So maybe it was something more than a cold. I don't know.
Okay. What symptoms were you getting with that cold at the time?
Bad sore throat. My glands felt quite big as well, so I was just really tired, really, no energy.
Were you short of breath at that time during the cold?
Yes, but not as much now. That's why I've come in now, because it's gotten worse. It's got a bit more noticeable. But the cold symptoms have gone away now, pretty much. I still get a bit of a sore throat every now and again.
Right, okay. When you're at rest, do you get short of breath?
No.
No. Okay. Ever had asthma?
No, I've never had asthma or any sort of chest problems as far as I can remember. Nothing like that.
And do you have a particular diet? Are you a vegetarian or anything?
No, I'm not a vegetarian, but I hardly eat any meat either. I eat a lot of fried rice and instant noodles from the university cafeteria. The food's quite cheap. I know I should eat fruit and vegetables, but I'm a student. I suppose my diet is terrible if I think about it. Some days all I'd have is instant noodles and some hot chips and the usual 4 or 5 cups of coffee.
You drink a lot of coffee then?
Yeah, it keeps me going with all the assignments and things.
Okay. Have you noticed any problems with abdominal pain or indigestion?
No, nothing severe, no.
Nothing severe. Have you had some from time to time?
No, not really. Well, I've had some mild discomfort occasionally, but that could just be indigestion, I suppose. I don't know, it's something I've had on and off for years, really. It's nothing new.
It's nothing new, okay. Any nausea or vomiting with this?
No.
What about your bowels? Have they been working normally?
Yes, been fine. I haven't had any diarrhea or anything.
In particular, not past any black or very dark motions?
No, nothing like that.
And what about family history? Is there a family history of people getting anemic, for example, for any reason, as far as you're aware?
No, not that I can think of.
No one's had any sort of blood disorders or anything?
No, nothing like that, as far as I'm aware. My parents are very fit and active, and my brother doesn't have any health problems that I know about.
Right, so they're all fine as far as you know. So, Daniel, did you have an idea in your own mind what this might be?
I thought it maybe could have been related to the cold I had, because one of my friends did have glandular fever around like a few months ago, because my glands were up. I thought it could be related to that.
This is the end of Part A. Now, look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete the answers as you listen to the audio. Now, look at the question 25. You hear a discussion between a doctor and nurse about different types of blood tests for leukemia. Now, read the question.
Hello, doctor. What are the different types of blood tests for leukemia?
Well, blood tests, such as complete blood count, can detect leukemia. A complete blood count determines the number of red blood cells, white blood cells, and platelets. Cytogenetics Analysis is a blood test in which a sample of blood is examined to check for changes in the chromosomes of the lymphocytes. Peripheral blood smear determines the presence of blast cells and shows the type and quantity of white blood cells. Other various blood tests may be ordered to see how organs are functioning and if they're being affected by leukemia. Question 26. You hear a discussion about different types of melanoma. Now, read the question. There are 4 major types of melanoma that have the potential for metastasis, with distinct characteristics. Lentigo maligna is often found on the head and neck region. Superficial spreading melanoma is more commonly found on the trunk, upper arms, and thighs, and is the most common form of melanoma in white races. Acrolentiginous melanoma is more commonly found on the hands, feet, and nail beds, which is similar to lentigo maligna and superficial spreading, in which it has a relatively long, flat phase before it penetrates into the deeper levels of the skin. Nodular melanoma can occur on any skin surface, but is found more commonly on the trunk, upper arms, and thighs. Question 27. You hear a discussion about lung cancer. Now, read the question.
Hello, doctor. What are the different types of lung cancer?
Squamous cell carcinoma, or epidermic carcinoma, usually starts in the bronchial tubes in the center of the lungs and can cause symptoms early on, especially hematypus. Large cell carcinoma often occurs in the outer regions of the lungs and tends to grow rapidly. Mesothelioma actually begins in the mesothelium, a membrane that surrounds the lungs. Small cell lung cancer usually grows in the central areas of the lungs, and most people have few symptoms until just before they are diagnosed. Lung carcinoid tumors are made up of cells called neuroendocrine cells. Question 28. You hear a discussion about non-inflamed comedones. Now read the question.
Hello, doctor. Can you please explain to me what are non-inflamed comedones?
With non-inflamed comedones, there will not be redness or swelling of the lesion. However, non-inflamed comedones may turn into a pimple when bacteria invade. Open comedones, or blackheads, is an accumulation of dead skin cells and sebaceous matter within the follicle. Soft-close comedones develop when a plug of cellulose debris and oil becomes trapped within the pore and are covered by a layer of dead skin cells. Hard-closed comedone, called milia, have very obvious whiteheads, which is not pus, but rather a mass of dead cells and sebum. Microcomedomes occur when the sebaceous duct and pore opening becomes blocked by excess sebum and dead skin cells. Every blemish begins as a microcomedome. Question 29. You hear a question about acnes. Now read the question.
Hello, doctor. Could you explain to me what are acnes?
Well, there are different types of acne which are not just classified by its severity. Acne vulgaris can appear on the face, back, shoulders, and buttocks. If you break out, most likely it is the acne vulgaris comedomal acne, appears as bumpiness, blackheads, which can occur anywhere on the face or body that can range from very mild to quite severe. Cystic acne is the most severe form of acne, which can occur anywhere on the face or body. Acne cysts occur deeper in the skin than the typical pimple, take weeks to heal, and can cause a lot of damage to the skin. Because they are so deep, topical acne treatments are not very effective. Instead, oral medications, like Accutane, are the best option. Nodule acne is another severe type of acne vulgaris. Acne rosacea is a type of acne that affects adults above 30 and occurs only on the face. Acne machantia is caused when there is excess heat, pressure, or friction on the skin. This type of acne is most common on the body, but can also occur on the face. Acne cosmetica is caused by products like creams, makeups, and moisturizers, and even certain hair care products cause this type of facial acne. People with excoriated acne chronically and excessively pick at pimples to the point of causing wounds. Question 30. You hear a discussion about athlete's foot. Now, read the question.
Hello, doctor. What are the different types of athlete's foot?
Athlete's foot is divided into three categories: chronic interdigital athlete's foot, chronic scaly athlete's foot, and acute vesicular athlete's foot. Chronic interdigital athlete's foot is characterized by scaling, maceration, and fissures most commonly in the webbed spaces between the fourth and fifth toes. With this type of athlete's foot, itching is typically most intense when the socks and shoes are removed. Acute vesicular athlete's foot is the least common type of athlete's foot, caused by trichophyton mentagrophytes, that is characterized by the sudden onset of painful blisters on the sole or top of the foot. This type of athlete's foot is also caused by jungle rot, a historically disabling problem for servicemen fighting in warm, humid conditions. Chronic scaly athlete's foot is caused by Trichophyton rubrum. This dermatophyte causes dry, scaly skin on the sole of the foot. The hands may also be infected, although the usual pattern of infection is 2 feet and 1 hand, or 1 foot and 2 hands, and these are most commonly seen in patients with eczema or asthma.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1, questions 31 to 36. You hear the discussion between a senior doctor and junior doctors about volvulvus. You have 90 seconds to read questions 31 to 36. Hello everybody. I am going to explain to you about volvulvus. The word volvulvus is derived from the Latin term. It is a subtype of abnormal gastrointestinal rotation. In volvulvus, a loop of intestines is twisted at a point along the mesentery, attached to the gastrointestinal tract. Volvulvus may result in bowel obstruction that is considered as a medical emergency. Because there is not a blockage, but there is also a compromised vascular supply to the gut. There are 4 primary mesenteries found within the abdomen, and as a result of it, there are 4 corresponding primary types of volvulvus: gastric, midgut, cecal, and sigmoid volvulvi. Gastric volvulvus occurs when our stomach twists at least 180 degrees around its mesentery, resulting in obstruction of the bowel. Patients with gastric volvulvus may be present with Borchards triad, which are spontaneous and severe epigastric pain, uncontrolled producing vomiting, noises without a vomit, due to the impossibility of passing a nasogastric tube through to the gut. There are 2 subcategories of gastric volvulvus. Organoaxial volvulvus tends to occur after traumatic events or hernia of the periesophageal area. The stomach rotates along its long axis, that is along the path between the pylorus and the cardia. This condition is usually symptomatic when the rotation is more than 180 degrees and causes ischemia in addition to obstruction. Mesenteroaxial volvulvus tends to occur very frequently in children. The rotation of the stomach along its short axis, that is along that path perpendicular to organoaxial, or the pathway between the lesser and greater curvatures of the stomach. The treatment of gastric volvulvus, which may involve an emergency laparotomy, insertion of gastrostomy, percutaneous tube, and hernia and diaphragmatic damage repair. The surgery is primarily aimed to reduce the degree of twisting and prevent any chances of recurrence while taking care of factors that create a predisposition. Midgut volvulvus begins in newborn with sudden bilious vomiting. In addition, the abdomen becomes tender as it fills with fluid that accumulates within the bowel lumen, and followed by inflammation of the peritoneum and shock. Patients with midgut volvulvus typically have a corkscrew sign visible on fluoroscopy, contrast examination, which is a spiral appearance of the bowel. Another imaging technique, such as ultrasound and computed tomography, show a whirlpool sign, which is used to denote twisting of the bowel on itself. A LAD surgical procedure is done to treat midgut volvulvus, which entails dividing the tissue that creates an attachment between the cecum and the abdominal wall called Ladd's bands, widening the mesentery of the small intestines, removal of the appendix and proper placing of the colon and cecum, Patients with sigmoidal volvulus often have abdominal bloating, constipation, and nausea that may or may not be accompanied by vomiting. Sigmoidal volvulus is considered to be associated with neurological pathologies such as multiple sclerosis and Parkinson's disease. The causes of sigmoidal volvulus include the South American Chaga disease, laxative use, and diets rich in fiber. A whirlpool sign is also seen in sigmoidal volvulus on imaging. In addition, a coffee bean sign may be seen on the abdominal X-ray that will look like an inner tube that is bent. In most of the cases, the insertion of a rectal tube is found to be successful in treating sigmoidal volvulus. Cecal volvuli are predominantly associated with two predisposing factors: lack of thorough peritoneal fixation and fulcrums such as abdominal masses or adhesions. Patients with cecal volvuli tend to have distended abdomens in addition to colicky, abdominal pain, and vomiting. Nearly half of the patients with cecal volvuli tend to have a cecum that is abnormally rotated in an axial plane, while the remainder have a cecum that inverts in addition to twisting. Treating cecal volvuli may involve laparotomy, hemicolectomy, or cecostomy. Now look at Extract 2, questions 31 to 36. You hear the guidelines given by the physician on how to cope up with Prader-Willi syndrome. You have 90 seconds to read questions 37 to 42. Rejection of kidney transplant. What should I do? Rejection is the primary and prominent complication that may arise after receiving a kidney transplant. Since the individual was not born with a transplanted kidney, his body will consider this new tissue is foreign, and as a result it will try to attack the new kidney to protect the body of the individual. Rejection is a common response of the body after the transplant surgery. Therefore, the patient must take appropriate anti-rejection medicine as prescribed to prevent rejection. There are two types of rejections that occur after the kidney transplant. 1. An acute rejection occurs usually any time during the first year of transplant and can be cured successfully, whereas a chronic rejection occurs gradually over years. The causes of chronic rejection are yet to be identified by the research, and the treatment of chronic rejection is often unsuccessful. Immunosuppressant or anti-rejection medicines decrease the natural immune response of the body to the new foreign organ. The medicines repress the immune system and prevent the body from rejecting the new organ. However, there are also chances of getting cervical, colon, and breast cancer in women and prostate and colon cancer in men. Significantly, it is very difficult to diagnose the kidney rejection in its early stages. Also, the rejection is often irreversible once it starts. Therefore, the organ recipients should never stop taking the anti-rejection medication even if they think the new kidney is functioning well. Discontinuing the anti-rejection medication will encourage a rejection to occur. The numerous side effects of the immunosuppressant or anti-rejection medications are usually manageable by the patients. Blood levels after having anti-rejection medications have to be examined regularly to prevent rejection and reduce the side effects. High blood pressure, weight gain, getting infections, and an increased risk of certain types of cancer are some of the common side effects of immunosuppressant medications. The three groups of immunosuppressant medications are induction agent, a powerful immunosuppressant medication given before the transplant or immediately after the surgery. Maintenance agents are the second group of immunosuppressant that have to be taken regularly throughout the lifetime. Rejection agents are the medications that are used for treating the kidney rejection. However, since the immunosuppressant medicines lower the immune system, there are high possibilities of viral and other infections. Therefore, diagnosing and treating the infections at the initial stage is the best method to maintain the body and the new organ healthy. It is very essential to wash the hands frequently or to use an antimicrobial gel during cold and flu season. The patient should report to the physician following any of these symptoms: sores, injuries, or wounds, especially those that do not heal, symptoms of urinary tract infection like a frequent urge to urinate, pain or burning sensation while urinating, reddish or cloudy or bad-smelling urine, symptoms of respiratory infection such as nasal congestion, cough, sore throat, and scratchy throat, running nose, or a fever. There are certain vaccines that will protect the body from infection. Also, certain vaccines are not good for a transplanted patient. For instance, the patient should avoid all live vaccines. Therefore, the patient should consult the transplant team before receiving any boosters or vaccines. The following are the common rules for receiving vaccines such as live vaccines, a flu shot, or hepatitis B. Hepatitis B should be received before transplant. Should avoid all live vaccines. Should avoid the nasal influenza vaccine. Should wait for at least 6 months after transplant or receiving a flu shot. Afterward, get a yearly booster injection. The patients who receive a live vaccine should avoid direct contact with the children received oral polio vaccine for 3 weeks. The children received measles or mumps vaccines. The adults received attenuated varicella vaccine to prevent zoster. The adults or children received the nasal influenza vaccine. The recommended vaccines are Haemophilus influenza B, diphtheria pertussis tetanus. Hepatitis B is safe before transplant. Hepatitis A should be given before traveling. Neuromax, single booster after 5 years of transplant. Influenza types A and B yearly. Inactivated polio. Meningococcus. Typhoid 6. The following live vaccines should be avoided: varicella zoster, smallpox, live oak typhoid, TY21A, and other newer vaccines, intranasal influenza, Bacillus calmette-guerin, yellow fever, mumps, rubella, oral polio, live Japanese bee encephalitis vaccine, and measles. except during an outbreak. The patient may develop diabetes after the transplant even if he did not have any diabetes earlier. This kind of diabetes is known as new onset diabetes after transplant, or NODAT, that can occur as a side effect of the anti-rejection medications. Kidney recipients are often at greater risk for heart disease. The many causes for heart diseases are diabetes, smoking, hypertension, overweight, high cholesterol, blood lipids, hypertension, and prolonged periods of dialysis. There are increased chances of cancer formation after the transplant. Therefore, it is very crucial to keep maintaining the immune system to prevent cancer formation. Since the immunosuppressive medications decrease the immune function, that will obviously decrease the defensive mechanism of the body against certain types of cancer, there are things that you can do to lower your chances of getting cancer. The most common type of cancer is the skin cancer that can result in the fatality of a patient. However, there are also chances of getting cervical, colon, and breast cancer in women and prostate and colon cancer in men.